Hi, this is Darcy Gaden, and I am just recording a PowerPoint with audio on the hepatic system just for review in case we run short of time this unit. We talked quite a bit at the beginning of the unit regarding the liver functions and how important the liver is in many things besides just drug metabolism, which I think is one thing that students automatically think about. So we're going to go review the functions here. So metabolic-wise, we know that it's very important for the manufacturing, storing, and excreting substances involved with metabolism, but in particular we know it's important for the regulation of glucose, and we know that glucose is stored in the liver in the form of glycogen, and liver can synthesize glucose and produce glucose, but it also can release the stored glycogen when needed. So regulation of glucose, fat, and protein metabolism is very important. As far as drug metabolism, there are important pathways for medication metabolism, and that involves conjugation, or what we call binding, of the medication with a variety of components in order to form a more soluble substances for excretion. And excuse me. So for drug metabolism, mainly it is done through this conjugation or binding process. So some of the medications that you should readily be aware of as far as the liver's function in metabolizing and detoxifying are alcohol, and then the drug categories listed there for you: barbiturates, opioids, anesthetics, amphetamines, sedatives. I know many people think right off the bat of acetaminophen. As far as bile goes, the liver is responsible for manufacturing and secreting bile, and the main role of bile is the breakdown of fat and absorption of dietary fats. Bilirubin excretion. The liver removes bilirubin from the blood and alters it and excretes it in the feces. And so we know that bilirubin is the byproduct and destruction of red blood cells. So again, it is done through excretion in the feces, and again, the hepatocytes remove the bilirubin and chemically modify it through a conjugation or binding process that makes it more soluble. So when we look at the conjugated and unconjugated bilirubin as far as lab values, this becomes important. The liver is also responsible for converting ammonia to urea for excretion, and remember, urea was that largest component in the excreted in the urine. So we do get rid of a lot of ammonia and this byproduct in this way. The liver also is responsible for forming and synthesizing plasma proteins, in particular albumin. Albumin happens to be 60% of proteins, and so we talk a lot about albumin having that pulling power, or albumin being responsible for maintaining the osmotic pressure. So it maintains plasma oncotic pressure, and that is basically maintaining that intravascular blood volume. If we have a low amount of plasma protein or albumin, we typically will have a lot of third spacing because there isn't that protein to maintain that oncotic pressure, which holds fluid in the vascular space, and so it moves out into the interstitial without adequate protein. Synthesis of blood clotting factors. Vitamin K is required by the liver for synthesis of prothrombin and other clotting factors. So we see the typical patient with liver dysfunction or cirrhosis that ends up coming in with lots and lots of bruising. We can see that bleeding underneath the skin because they have inadequate clotting factors due to their liver disease. This is just a picture of the liver and the different. Want to touch base briefly on the hepatic circulation, and just reinforce that there are basically two sources of blood flowing into the liver. 75% of the blood supply does come from the portal vein, which the portal vein drains the GI tract and is rich in nutrients. So that's that mesenteric artery and venous system that we talked about during the GI system. So 75% of that blood supply drains into the portal vein and then to the liver. The remainder comes through the hepatic artery, but both have oxygen rich and full of nutrients to supply the liver for functioning. And then once it's through the liver, basically that's returned into circulation via the hepatic veins to the inferior vena cava, and then it's circulated back through the coronary system and the venous system back up to the heart. As far as assessment, one of the biggest, most crucial parts of the assessment for liver disease is the health history. So we need to find out, have they been exposed to any hepatotoxins or any other infectious agents? Have they had a recent travel history? And then certainly we do look heavily on alcohol and drug use, and in particular, the drug categories that we talked about for metabolism, acetaminophen, also looking at valproic acid or Depakote, and other medications that can cause some hepatic dysfunction. Lifestyle behaviors, important as far as injectable drug use, sexual practices, those sorts of things, and then certainly always a current medication list. As far as the physical examination, it's not like we palpate the liver on every patient, but certainly we're looking at the skin inspection. We're looking at the mucosa and the sclera in particular, checking for jaundice. Also know that we can see jaundice very well on the abdomen, on the torso, in babies and infants and adults too. So also looking at the abdomen in regards to ascites and if they have extra fluid and that third spacing that we're talking about. And I think you'll find, if you have not assessed a patient with ascites yet, that it's very different from a distended abdomen. It definitely looks more like a fluid-filled distension versus firm and distended from other reasons. And then certainly liver palpation, and we'll talk about how you would do that. Looking at the neurological and cognitive status is also very important, and we'll get to talking more about hepatic encephalopathy in a little. Some of the general signs and symptoms that suggest liver disease, then, you really must know these. You should be able to look at each of these clinical signs and symptoms and be able to document behind them what the pathophysiology is, why you would expect to see any one of these that would be suggestive of liver disease. So I'm not going to talk about them now. This might be a good thing for you to review afterwards, just to make sure that you can readily understand why you're seeing what you're seeing and not just memorizing a list here. Again, this picture is on page 1288. We do place one hand under the right lower rib cage, and then we press down with light pressure. We're going to document any tenderness, and certainly any tenderness implies that there's some sort of an acute enlargement, stretching of the liver capsule, and we document the degree that the liver extends below the right costal margin. So when the right costal margin is right up under that rib cage there, that rib cage line. So we document that costal margin as for other things, for respiratory rate and effort and all that. But we also do document if the liver edges are extending well below that. That's not typically normal. If you feel on yourself, you have to really feel almost up and under that right costal margin to feel your liver, assuming it's not enlarged. Some age-related changes then of the hepatobiliary system. These are on page 1287 of your textbook. we see a decrease in blood flow to the liver. We know that elderly have a reduced drug metabolism and drug clearance capacity. So just as we closely look at the renal clearance and reduction in the kidneys, we certainly need to be looking always at the drug dosing for elderly, because most of the medications are either metabolized and excreted through the liver or the kidneys. Decreased size of the liver, we know that they do have an increased prevalence of gallstones and increased cholesterol secretion in the bile. Now, typically the changes, just kind of for your information, the changes of age-related changes are usually proportionate with regard to the size of the liver. So we typically don't see liver function test changes. They shouldn't be altered just with the normal age-related changes. So that's important to know as we start looking at labs. So here are the liver function tests, and these are typically pretty challenging for many students, for staff. There's a lot of them. We will not expect you to have these memorized per se, but you would want to know what they're testing, what they're checking for, at least begin to have some sort of an idea. So we'll try to emphasize, for example, ammonia is important, and prothrombin time, the cholesterol. Those ones you should know. And protein, we've been talking about them all year. But some of the lab values like the AST and ALT, I don't have those memorized. I usually kind of remember the range, but I don't necessarily have them memorized, or wouldn't expect you to have them memorized, but to look them up in a reference book. But you should know, for example, if the ammonia is high, what might we see? What medication might we give to reduce ammonia? That sort of thing. If they have a prothrombin time that is elevated, they're at risk for bleeding. What are we doing for that patient with liver disease? So it's application of the liver function test that we would expect you to be, moving in that direction. So I'll just talk a little bit about each of them briefly, and I will want you to look in your lab books to kind of, increase and expand on your notes here. It's difficult just talking over the slide and not in class on this sort of a thing. But the total bilirubin, you have the numbers there, 0 to 0.9. And again, this just measures the ability of the liver to alter and excrete bilirubin. And we can see that increased with liver failure. And then the AST or the SGOT, the AST stands for aspartate aminotransferase, and this can be elevated in liver cancer. One thing I want to mention is that the AST is an enzyme found primarily in heart muscle and liver. And so I know on the tele unit we have been seeing some ASTs that have been elevated, and they can be elevated after an acute MI. But they remain high in liver disease. So the AST you may see also with coronary or acute MI, but it wouldn't stay elevated continually like it would with liver disease. The ALT then, the alanine aminotransferase, this also is high. There's a high concentration in liver cells, and it's useful in evaluating hepatic disorders. And it's kind of used to confirm liver damage. Typically, if it's elevated 20 times the reference range, it's really a confirmation of some liver disease that's present. The ALP, the alkaline phosphatase, this is also found primarily in liver, gallbladder, intestine, and bone. So it's not specific just for liver, but it does help diagnose hepatic and bone disease, both. And then the ammonia. The ammonia is very critical because we know that NH3 or ammonia is produced by the breakdown of proteins, primarily by bacteria in the intestines. So ammonia, again, remember, a primary function of the liver was to excrete ammonia in the form of urea. And so if this isn't happening, in liver failure, we'll have a buildup of ammonia. And we know that we treat this high ammonia with lactulose as a primary agent, and we'll talk about that in a bit. Prothrombin time then, there's the baseline there. And the cholesterols I'm not going to review. You should remember that the HDL is the high density, and that's the good cholesterol, and the LDL is the low density, and that's the, quote, bad cholesterol. The HDL, remember, basically helps carry fat away from arterial walls, and the LDL deposits it in the arteries. So that's why we want it to be a high HDL, so that we have more of that good cholesterol that's carrying all that fat and plaque away, rather than have the LDL that's depositing it. And then protein, total protein, or albumin, 3.5 to 5. So you should, have a pretty good idea of the reference range for that. Liver biopsy. If they are needing to do a liver biopsy, typically it is done in radiology. It's done percutaneously, and it's usually ultrasound guided in that department, done by radiologists. And they'll remove a small amount of the liver tissue, typically through needle aspiration. I do know that it's a very uncomfortable procedure as far as the tool that actually biopsies. And if you think of how deep the liver goes, it's not just a superficial right underneath the skin. As far as pre-procedure, think of your clientele that may be having a liver biopsy. They may have altered coagulation studies, and platelet counts and bleeding times may be altered already, and they may be at risk for bleeding, so they definitely need to know this. Certainly, as with anything, we need an informed consent. They need to be educated what to expect and steps of the procedure, and really to be forthright in saying that it's not comfortable, that it is going to hurt, but that it should be brief, and then a baseline set of vital signs. During the procedure, they will expose the right side of the upper abdomen, and the main thing here is that the patient is instructed to hold their breath after exhalation for biopsy, and this basically moves the diaphragm out of the way. So the instructions and guidelines for assisting with a liver biopsy are on page 1292 and 1293. So you should look at all those and make sure as an RN that you would be able to assist with this type of a procedure should you need to. And then post-procedure, of course, the most important thing to watch for as far as complication is bleeding. So they'll immediately put the patient on the right side and on that side of the biopsy to provide pressure and keep them immobilized to decrease blood loss from the site. Bed rest. Look at your policy, but it's approximately 2 hours is typically what I have done after liver biopsies, where I've been involved taking care of these patients quite a few times over the years. And then more frequent vital signs, and instructing them not to cough or strain, just to hang tight for a bit after that procedure until we know everything is stabilized. And this is just showing the picture basically of why we have them exhale and hold the breath, as far as what that does to the diaphragm and moving that out of the way. Other diagnostic tests, the HIDA scan is one that you've probably heard more commonly, and this is the same as a gallbladder scan. And so a radioactive chemical is injected IV, and this test chemical is basically removed from the blood by the liver and secreted into the bile, which of course is produced by the liver. So this test chemical basically goes where bile goes. So if they put a test chemical in, they can see exactly how the bile is traveling, if there's any obstructions. It takes about 2 hours for this to travel through the biliary system, and the camera, they take x-rays basically throughout this process. And CT and MRI can be done, of course, and then the ERCP, endoscopic retrograde cholangiopancreatography, and that's just looking at basically the biliary, the gallbladder, and all the bile ducts and the pancreas. And I'll refer to a really, really nice picture that shows you, it's on page 1350, that shows you how this is done. I know I was always puzzled how they were getting to the duct system through the esophagus and stomach and duodenum. I wasn't making that connection, I think, early on in my career. They do need to be NPO for a minimum of 6 hours because it is an endoscopic procedure. All of the same precautions and pre-procedure nursing care and post-procedure nursing care applies to the patient having the ERCP done. They do use the conscious sedation. Remember, that's the Versed and fentanyl combination that RNs would need to be trained to do. They would have a cardiac monitor on and an O2 sat monitor continuously while they're under conscious sedation. Other medications that will likely be used, glucagon or anticholinergic agents such as atropine may be used, and what this does is it basically eliminates or decreases duodenal peristalsis, and that is very important for the actual cannulation once we get to the into the duodenum, that they need to cannulate through the ampulla of Vater to get into the duct system. And that's, I guess, all I needed to. So here's the picture, and this is on page 1350. So it shows you see that endotracheal, or excuse me, the endoscope coming down through the esophagus into the stomach, and then you see it coming into the duodenum, and basically, once it gets to the descending duodenum, they will find the ampulla of Vater, and then that is how they access through there. That gets into the pancreatic duct, and then they can thread it up through the bile duct and see everything that's going on in the bile duct system, the common bile duct, the pancreatic duct, and they can see if anything is occluding any of those areas, impeding that flow of bile and or pancreatic secretions. Common symptoms of hepatic dysfunction then are listed. And again, as with anything else, when we just think about what the liver does, you should be able to look at this list and say, if the liver is not functioning, based on my knowledge of what the liver does, this is what's going to happen. And so we know that jaundice can result from that increased bilirubin, because the liver is not able to excrete it as it normally would. And in the second bullet, that portal hypertension, ascites, and the esophageal varices, leading to the GI hemorrhage. Of course, the sodium and water retention, which is what is contributing to the portal hypertension and the ascites. All of that we will talk about in great detail here in a little bit. Other nutritional deficiencies, we know that if they have alcohol use or drug use as a potential causative agent, certainly they can be malnourished just because of not eating healthy, but we also know that the liver is responsible for storing certain vitamins, and so they may have nutritional deficiencies just from that part of it as well. And then hepatic encephalopathy is basically when we have a certain amount of ammonia accumulation. This basically affects our brain cells and will result in the hepatic encephalopathy as well. There are several different types of jaundice. We do have them listed on the next couple slides. I think the biggest thing that I want to emphasize is that just understanding jaundice as far as what you're going to see, where are you looking, what are the labs going to look like. The different forms of jaundice, there are 4 different types of jaundice. Differentiating between each type isn't as critical as really understanding jaundice in general, I think. But I will highlight a few key points. So we know that jaundice is when the patient has that yellow-orange discoloration of the skin and mucous membranes, and that this is caused by a disturbance in the bilirubin metabolism. Okay, we all know that. It results in hyperbilirubinemia, and we have an elevated bili in the blood. And just to refresh, the normal was 0 to 0.9 milligrams per deciliter. So typically when we get anywhere, greater than 2.5 or so, 2.5 milligrams per deciliter, this is when we certainly would see clinical evidence of jaundice. And then as it gets higher, of course, it's just going to be more prevalent. Hemolytic is when you have increased destruction of red blood cells, and the most common example of this is with a transfusion reaction. Hepatocellular is, you'll see the causes hepatitis, cirrhosis. Basically, it occurs following infection, drug toxicities, or alcoholic cirrhosis, and it's It's caused from that cellular damage. Obstructive jaundice, then we'll see this when we have obstruction of bile ducts by a stone, inflammation, tumor. So this is more of a problem with a plugged bile duct, and bile cannot flow normally into the intestine, and so we have an increase of bilirubin that can't be excreted through the GI tract. So the bile backs up into the liver and the whole bile duct system, and then it's reabsorbed into the blood. And when it's reabsorbed into the blood, then it's carried to the entire body. It stains the skin, it stains the mucous membranes, and that's why we get that orangey yellow discoloration. That same bile backing up and that substance that basically is absorbed back into the blood system then also can be excreted in the urine, and that's why we have a deep orange or even kind of a tea-colored urine coloration, and we'll talk about that cola-colored urine and why it's, that's basically why it looks that way. And then hereditary, there's a couple rare disorders that could result in a hereditary jaundice as well. So again, if we look at the signs and symptoms though, if we look at jaundice in general, you'll see documentation about scleral icterus, for example, and that's just the technical terminology for yellowing discoloration of the sclera. We'll talk about pruritus and itching. Well, that itching is basically secondary to an accumulation of bilirubin on the skin and also ammonia on the skin. As far as the clay-colored stools, that's a key factor with hepatic disease. And if we do, for example, have complete obstruction of flow of bile into the duodenum like you would have with obstructive jaundice, basically we don't have that bile to break down the fats, and so without that it will result in a clay-colored, a gray-colored stool. And then we talked about the urine being more of a dark orangey color, tea-colored when we have this bilirubin that's excreted in the urine. Okay, portal hypertension. This, I think, is the pathophysiology is quite simple. If we have obstructed blood flow through a damaged liver, we're going to have an increased blood pressure, and we're going to have increased blood pressure in the portal venous system that we talked about the anatomy a while ago. If we have obstructed blood flow of the portal venous system, then we're going to end up with esophageal varices and ascites. So the main causes are the hepatic cirrhosis, and we know that that is commonly associated with portal hypertension. So they basically, go together. All of the anatomy and physiology for portal hypertension, ascites, and esophageal varices, they all link together. And we see that on this next slide. Basically, the major consequences of portal hypertension are ascites and varices. So the ascites is the increased sodium and water retention, and what happens is the liver is unable to metabolize aldosterone. So we know that aldosterone is a hormone that's responsible for holding on to sodium and water. So if the liver cannot metabolize aldosterone, we're going to hold on to more sodium and water. There's going to be more aldosterone left in the body because it's not getting metabolized. We also know that another huge contributor of the ascites is that decreased synthesis of albumin, and that lower level of albumin will basically result in a decreased osmotic pressure. We don't have enough albumin to keep fluid in the intravascular space, and so they end up third spacing it and end up with ascites in the peritoneal cavity. As far as varices then, we have increased pressure with that increased blood pressure in the portal venous system, and it's prone to rupture and rupture any of those vessels and can lead to a massive hemorrhage and death. And then keep in mind that this population may also have deficient clotting factors and prolonged PTs and PTTs, so it's just even worse of a scenario when they have the varices and difficulty clotting as well. So here's the pathophysiology. This is in your textbook on page 1294, and it just starts at the top and looks at cirrhosis and portal hypertension. And the splanchnic arterial vasodilation, splanchnic just refers to arterial blood supply to any of the large interior organs, especially abdominal organs. So just think about vasodilation, and with that you will have a decrease in circulating arterial blood volume, decreased blood volume. And then with the decreased blood volume, we go back to the fluid regulation cycle, way back from fluid and electrolytes. If we have decreased blood volume, we're going to have activation of the renin-angiotensin-aldosterone system, because we're going to have the sympathetic nervous system or fight or flight response activated. With that, the kidneys are going to retain sodium and water, resulting in hypervolemia. And so now we have increased blood volume, and then we'll have persistent activation of the systems, and we have retention of sodium and water, we have the ascites, we have the edema, and then we have the continued cycle, because then we have portal hypertension again, and then now comes the vasodilation, and then the activation of the sympathetic nervous system, and it's just a vicious cycle that we see with this cirrhosis and portal hypertension. As far as ascites, we know that this is accumulation of fluid in the abdominal cavity, and patients can have anywhere from, however many liters, but 15 liters or greater is not uncommon as far as albumin-rich fluid that accumulates in the peritoneal cavity with somebody with cirrhosis or severe liver disease. So think about that. 15 liters is a lot of fluid that's sitting in that area. So we know that we'll see the flank bulging in a supine position. I'll show you a picture here coming up. We'll look at percussion and dullness in the area where the fluid is. You can certainly tell that it's more fluid filled, and you'll see that fluid wave. If you're tapping the belly on one side, it'll just ripple across to the other side. And then very important to be thinking about measuring abdominal girth. So if the abdomen is protruding more than just a normal for the patient's baseline, you should think about getting an abdominal girth measurement to evaluate that. And certainly acrid I&O is in daily weights is crucial for the diagnosis and treatments of ascites as well. So increased weight, shortness of breath and discomfort related to the enlarged abdomen, everything's pushing up on the thoracic cavity. You also see striae, the purple striae and distended veins are more visible on the abdominal wall, and that's just showing that portal hypertension that you see underneath the skin. And then other fluid and electrolyte imbalances are very, very common as we have all of the shifting of the fluid from the vessel to the interstitial, and so the vascular space thinks that it's low on volume, and it's low on potassium, and it's low on all of these other electrolytes. So as far as management, we want to make sure that we decrease fluid retention, and we can do that by having a low sodium diet, and certainly anything that we can do to stop retaining sodium and water. Now make sure if somebody also has renal impairment to be careful about those salt substitutes that contain potassium, because we know that that's with renal impairment they would be retaining potassium, and so we don't want them to have salt substitutes containing K. Diuretics, they will be on spironolactone typically, which is a K-sparing diuretic. Bed rest, because we want to decrease activation of the sympathetic nervous system. And then they will likely in many cases have a paracentesis to remove fluid from the peritoneal cavity. And here's just showing that the fluid goes to the dependent areas. So, depending on if they're in bed or standing or which side they're lying on, it's going to be dull in the dependent area as far as percussion, because that's all the fluid-filled area is going to result in that dullness. And you'll have more of a tympanic sound at the top of the area where there's air and not fluid. This is just showing a nice picture, I think, of a paracentesis. They do this in a sitting position. They typically have them sitting, actually even maybe at the times that I've helped with it, leaning over a bedside stand. And so again, the paracentesis is going to remove fluid from the abdominal cavity. On page 1296 and 1297, there's some important information on assisting with a paracentesis, because this is something that you likely will do in your career at some point in time. And so again, sitting position, so the intestines will float away from the site of the paracentesis. Very important that we're checking blood pressures and heart rates and vitals every 5 minutes. We're watching for signs and symptoms of hypovolemia and electrolyte imbalance as we're pulling off large amounts of protein-filled fluid, and all of that fluid has electrolytes that we're losing along with it. So they say up to 5 to 6 liters is a safe amount during a paracentesis. If there's a lot more than that, they typically will wait and do it on a different day. And many times with a paracentesis, they'll also have them on albumin or other colloid or protein that will help keep fluid, help with that osmotic pressure, and prevent more from being shifted into the third space. As far as esophageal varices, bleeding from esophageal varices occurs in a third of patients with cirrhosis, and mortality rates from even a first bleed can be up to 50%, and that increases greatly the risk of death with each subsequent bleed. So this is a very serious illness, and if somebody presents to the emergency room with esophageal varices. So by definition, you'll see the dilated tortuous veins, usually found in the lower esophagus, the submucosa of the lower esophagus, almost always caused by the portal hypertension. And of course, the portal hypertension is due to obstruction of the portal venous circulation within the damaged liver. Again, it can be life-threatening because it can result in hemorrhagic shock. And basically, if they rupture, we're looking for the signs and symptoms of shock. So management is going to be assessment and treatment of shock, immediate and endo to identify bleeding sites may be an option. Certainly intravenous fluid replacements as one of our key treatments for shock. As far as the medications go, on page 1304 you do have a table that talks about management of a patient with esophageal varices, and it has some of these medications listed there. Vasopressin or pitressin, I can't talk. Vasopressin produces vasoconstriction of the splanchnic arterial bed, which will help decrease portal pressure. Vasopressin is not, however, specific just for the splanchnic vasoconstriction, so it will also cause vasoconstriction of coronary arteries. So that's why you see vasopressin plus nitroglycerin. Nitroglycerin is given kind of prophylactically when you're giving vasopressin, because so that it prevents the side effects of vasoconstriction of the coronary vessels, which could lead to angina or ischemia. Somatostatin, however, or sandostatin, is one that we use very readily because it decreases bleeding without vasoconstriction effects of vasopressin. It's selective only to the splanchnic vasoconstriction and not vasoconstriction of other arterioles. Balloon tamponade, the Sangstaken Blankmore tube, is an NG tube that is used that has ports for compression of the bleeding varices by balloon. We also can do ice lavage through the Blankmore tube. And there is a picture on, let me just see here, on page 1301, there's a picture of the Blankmore tube, so you can look at that. And you can see the different ports. One's for the esophageal balloon, one's for esophageal aspirate or gastric balloon. So basically you have balloons and ways to aspirate in both the stomach and the esophagus. So it's a 4-lumen nasogastric tube used for compression of bleeding esophageal varices. And here's the picture. Okay, as far as hepatic encephalopathy and coma, this is also a life-threatening complication of liver disease. It does result from accumulation of ammonia, primarily ammonia and urea, but other toxins and other metabolites that are in the blood as well. And it does represent the most advanced stage of hepatic disease and hepatic encephalopathy. And of course, the biggest things that you would expect are the mental changes and the motor disturbances and all of those things that would affect our brain and our neurotransmission. So asterixis, constructional apraxia. If we look at what those mean, asterixis, there's a picture on page 1306 that shows you what that is. It's basically also termed a liver flap, and it occurs in hepatic encephalopathy, and the patient basically holds their arm out with their hand held upward in dorsiflex, and within a few seconds it falls down. And so they call it a liver flap, and because their hand just kind of flaps down once they hold it up. So I have only seen this once before in my career, but it was definitely very, very evident. A patient had an extremely high ammonia level, and development of a hepatic encephalopathy was the diagnosis. So as far as management goes, besides just checking the neural changes and keeping a patient safe, INO and daily weight and vital signs are important. Lactulose, though, is primarily, we can give that oral or through the NG, and this is going to help the ammonia bind. It's going to bind to the lactulose and be excreted in the stool. So we need to understand lactulose. You need to look in your pharmacology book, and we don't hold it thinking they're having diarrhea. They're expected to have some diarrhea. We are getting rid of the ammonia that is toxic in their blood at this point in time. Very critical. Now, decreased protein intake certainly would be a possibility as far as diet. Antibiotics, neomycin, what these antibiotics can do is they can decrease the ammonia levels by decreasing bacteria in the GI tract, which in turn, the bacteria produces ammonia. So this is why we can give antibiotics or neomycin. It's decreasing the bacteria in the GI tract, which then will decrease the production of ammonia if we have less of it. We also can have somebody hooked up to GI suction as a way of decreasing absorption of ammonia from the GI as well. So decreased production of nitrogenous waste and ammonia, and correcting fluid and electrolyte imbalances, and hypokalemia is very common. Alkalosis is very common. So we're going to be treating with the lactulose and really watching the fluid and electrolytes very, very closely. I'm not going to talk about each of the forms of hepatitis. I'm really going to just briefly go past them. I think hepatitis should be something that you've really had a good foundation in your PN programs and even your clinical careers so far. But basically, I just want to say that you should be able to know that hepatitis is a widespread inflammation and necrosis of liver cells. It will result in decreased liver function over time, and that there's 5 different types. The biggest thing that you want to know about the different types is how they're transmitted, fecal, oral, blood, and then what we can do to prevent. The general signs and symptoms of hepatitis, you should be able to look at this and, again, write down the pathophysiology for why you're seeing what you're seeing. Okay, Hep A is here. We know the big one there is the fecal-oral transmission. We see it with, it's 20 to 25% of the cases of clinical hepatitis are Hep A, and this is food workers, poor living conditions, third world countries, and typically there is a vaccine that you can do if you're traveling, and it's a 2 or 3 series vaccine depending on age. And that's the gist of Hep A. Hep B, we know we have the Hep B vaccine and universal precautions for healthcare workers, so I think you're well informed with hepatitis B. Of course, immunizations for high-risk persons and screening of blood donors and all the needleless IV systems, all of these things are very important for decreased incidence of hepatitis B in healthcare workers. As far as hepatitis C, this is the most common bloodborne pathogen, so much more common than HIV or any of those forms. Basically, Hep C can be transmitted with, if we're not using correct technique and universal precautions and preventing needle stick injuries, etc. So very important that we have good practices at all times. And then Hep D is a Delta virus. It requires hepatitis B surface antigen for its replication. You won't get D unless you have B, basically, is what it's telling you. And so the risk factors are there, Hep B patients, and symptoms are similar to Hep B, and treatment similar to hepatitis, that should say hepatitis B. Okay, and then Hep E is also fecal oral. So A and E are fecal oral, and B, C, and D are all bloodborne. So it's actually pretty simple to remember. So hepatitis management, greatest fatigue occurs in the anecteric phase. Before they get jaundice, they'll have muscle atrophy and generalized weakness. Really important that we improve their nutrition and have their diet high in protein, and only if there's no risk for hepatic coma. If they're at risk for hepatic coma or encephalopathy, we wouldn't want to increase the protein. But typically, if they're not at real great risk for that, we do want to look at vitamin supplementations, and because the liver can't store the vitamins that it normally should, no alcohol, and increase carbohydrates and increase protein. Prevent bleeding because of the decrease clotting factors. Be real mindful if you're going to give an IM or not, and prevent falls. Improve mental function, and we do that primarily through decreasing the ammonia levels and giving them the lactulose. That will help a whole bunch. And of course, patient education. Okay, as far as cirrhosis is chronic scarring of the liver, and it's irreversible, and it's a chronic liver disease, and basically the most common type is the alcoholic cirrhosis that unfortunately we see a fair amount of, and you will likely run into in your career. So we'll focus on cirrhosis. Again, the primary risk factor is alcohol consumption, and causative agent is alcohol consumption. Men greater than women. Basically, we have destroyed liver cells that are replaced by scar tissue, and then the scar tissue exceeds the normal liver tissue. I do have listed compensated and decompensated. This is on page 1319 of your textbook. But obviously, if they get to a decompensated cirrhosis, this is more significant. And so I'll just look at that column as far as the decompensated, and just say that, they're hallmark symptoms of failure of the liver. Again, if you look at what the liver does for its key functions, if we shouldn't be surprised when we see decompensated cirrhosis involves ascites, and decompensated cirrhosis involves jaundice. All of the next three, weakness, muscle wasting, and weight loss, those are all as a result of decreased protein. Purpura and any other form of bleeding under the skin is just looking at decreased platelets and decreased clotting factors. And sparse body hair is a result of decreased metabolism of sex hormones and steroids. So think over and over, we need to think about what does the liver do? And so if we have decreased metabolism of ammonia, we can have hepatic encephalopathy. If we have decreased metabolism of aldosterone, and aldosterone's function is to hold on to sodium in water, well, we're going to have sodium in water retention, and we're going to have ascites and weight gain and resultant increased blood pressure and portal hypertension. So all of the functions really flow into the signs and symptoms very well. As far as complications, liver enlargement, portal obstruction and ascites is a late manifestation. Could end up with infection or peritonitis. Again, the varices, the obstruction and the of blood flow results in the formation of collateral blood flow in the GI system, although this collateral blood flow then is very, delicate, and so it's with high pressure it is likely to burst, and then we'll have bleeding varices. Edema, decreased plasma albumin, and overproduction of aldosterone are the main causes of the edema. And then vitamin deficiency and anemia and mental deterioration if they with the impending hepatic encephalopathy. So there is no cure as far as cirrhosis. We're basically treating the symptoms. So vitamins and nutritional supplements to improve nutrition, antacids that might help decrease gastric distress and possibility of GI bleed, case-sparing diuretics to decrease the ascites, the spironolactone, that'll work opposite on that aldosterone retention. Adequate diet, of course, avoiding alcohol, and then colchicine. It can be research shows that this can help reverse some of the fibrotic scarring and fibrotic process that happens with cirrhosis, and so that is why that one is there. You do have care plans on page 1323 to 1332 for liver dysfunction, regardless if we're talking about whatever type of liver or hepatic dysfunction, cirrhosis, to other liver disease. Most of this overlaps, and most of the signs and symptoms and treatment and diagnostic testing is virtually all the same. So typically if you know one, you should know them all. So anyway, on the care plan, promoting rest and increased in Fowler's position to help with the breathing and oxygen availability, and the improved nutritional status is there, the high protein, high calories, vitamin supplementation. Skincare is on there. Think about if they have edema, the high risk for skin breakdown, as well as the itching that they can have as we have the ammonia on the surface of the skin, reducing risk for injury, and then managing any complications and or preventing complications such as bleeding and hemorrhage and the encephalopathy, and then all the complications that can come with fluid volume excess. Liver transplantation, there is a picture on page 1337 of the how the transplants are done. It's used to treat life-threatening end-stage liver disease. And you'll see on the picture how they reconstruct the vasculature in the biliary tract. But again, success really depends on successful immunosuppression and being able to be on meds and corticosteroids and maybe Imuran and other medications that they would be on for life. Okay, functions of the gallbladder. We said that the gallbladder stores the bile. And then when food enters the duodenum, the gallbladder contracts and the sphincter of Oddi relaxes and then basically allows bile to enter the intestine. And there is where it's reabsorbed and then it gets into the portal venous system, returned to the liver, etc. But basically we know that basically, we need the this bile entering at the duodenum for breakdown of fat. So here's the anatomy, and this picture is on page 1346 as far as looking at the biliary tree and the pancreas. Cholecystitis is just inflammation of the gallbladder. I know you've taken care of patients with cholecystitis or lap choles, and so they typically are going to have that pain and tenderness of the right upper quadrant. So anytime we're thinking right upper quadrant, we're thinking liver or gallbladder. The pain may radiate to the shoulder, and they may have nausea and vomiting along with it. It may occur after having a fatty meal. Risk factors are on page 1348 of your textbook. Obesity is a contributor. Women, especially multiple pregnancies, and Native Americans and Hispanics are more common. I'm not really sure why, but that is a potential increased risk factor there. So what's it going to look like? Some people don't have any pain at all. Many people can have kind of acute attacks and not come in, and then they go away quickly, but then they have them more frequently over time, and so then they end up coming into the doctor. But so it really varies as far as intensity and severity and frequency, but typically they have epigastric distress, they have fullness, they have distension, and they have the pain in the right upper quadrant. And it typically does occur after meals. Most people, unless they come very, very late, would not have the jaundice or dark-colored urine or clay-colored stools. This would be a later sign and symptom, all of those, not an early manifestation. This diagnostic testing is on page 1349 of your textbook. We've talked about most of them already, so I'm just going to let you look at that on your own. And then as far as management, on page 1357, there's a nice table on the management of cholelithiasis and management after a laparoscopic cholecystectomy. And it talks about diet and medications and looking at low-fat diet and other medications that they may be on to help with that as well, and mainly the epigastric discomfort. And cholecystectomy, it's a pretty simple routine procedure. Some places of the country they go home the same day, otherwise they stay overnight one night, assuming that the gallbladder isn't totally necrotic. Then they might be in a little bit longer for some antibiotics. So it's just showing you how they have typically 4 different lap sites, and you'll see the 4 different types of instruments that they use for the lap chole. And prior to the laparoscopic, patients had a big incision for a cholecystectomy when they did an open cholecystectomy. Haven't taken care of a patient with an open cholecystectomy in a while, but have in the past a couple times when the gallbladder has been that inflamed that they really need to go in and open up and clean up and around so that they didn't form an abscess, and then get drains in place that would drain appropriately. And here's an example of a T-tube placed in the common bile duct for drainage. Bypass that one. Okay, pancreatitis then, inflammation of the pancreas, can be caused by obstruction or hypersecretion, and accompanied by hypersecretion of the enzymes. And the pancreatic duct joins the common bile duct and enters the duodenum at the ampulla of Vater. And we know that surrounding the ampulla of Vater is the sphincter of Oddi, which basically will control the rate at which secretion from the pancreas and gallbladder enter the duodenum. So again, look at the picture on page 1346 for that anatomy. %80 of patients with acute pancreatitis have biliary tract disease of some sort, may have gallstones entering the common bile duct that lodge, or other means that basically obstruct the outflow of the pancreatic enzyme, because again, remember, those both join up, the bile duct system and the pancreatic duct. and meet up at the ampulla levator. So there typically is some sort of obstruction going on. We know that pancreatitis can be associated with long-term alcohol use as well as obstructed biliary disease. Symptoms are typically epigastric, that middle upper abdominal area. They're typically very severe and very steady, needing IV narcotics and opioids for pain control. May have some improvement with sitting in a flexed knee position and more of a fetal position. May have fever, maybe have nausea, vomiting. Any of the signs and symptoms listed are fair game. What you'll notice for labs, though, is the increased amylase and lipase. So again, go ahead and look up the amylase and lipase and why they're elevated. But again, the amylase is responsible for carbohydrate digestion and the lipase is responsible for fat digestion. And so we can see those be elevated with pancreatitis. Management is NPO, IV hydration, parenteral nutrition perhaps. Pain management is critical. Demerol versus morphine. Why I have this on here is that morphine is thought to cause spasm of the sphincter of Oddi, and so they don't say it's contraindicated, but use cautiously. However, in clinical practice, I don't know that you will see this. It's really debated whether or not this is really a big issue or not. And typically many feel there's many more problems with Demerol as far as side effects and seizures and all that than there is with morphine. But I just want to throw that out there because I know in the textbook WISE it says that morphine can be contraindicated with pancreatitis. Intensive care, as far as correction of fluid and blood loss and the low albumin, typically they may be, depending on the severity, be more of an ICU type patient, so they can be monitored more closely. They're typically on antibiotics to kind of reduce some of that inflammation. Respiratory care, if need be, biliary drainage and stents or drains that might be necessary. Surgical intervention is pretty rare, but is potentially possible. And then post-acute management, H2 blockers can be helpful for the symptom management. You do have care plans on page 1364, 1365, 1366, 1367. So there you have a whole 4 pages of care plans for pancreatitis to further look and make sure you understand all there is to know about that. The last slide then is just talking about cancer of the pancreas, and it is the 5th leading cause of cancer deaths. Typically, people with pancreatic cancer usually have a poor prognosis. As you can see, there is fatality usually within 6 months of diagnosis. Symptoms don't really appear until it's well advanced or there's metastasis, so unfortunately not a lot of real good outcomes with cancer of the pancreas. Thanks so much. I hope this was helpful and not too boring. There's a lot of information with hepatic disease, so I tried to hit the highlights for your benefit. Thanks so much.